Hey everyone, welcome to another session of Virtual Global Spine Conference. It's my pleasure to introduce one of my future colleagues at the University of North Carolina, Dr. Deb Bhowmick. Deb is a complex spine surgeon. He's going to be speaking to us today about craniocervical junction indirect decompressions. Thanks for being here, Deb.
Thanks for having us. Thanks for having me. And I look forward to working with you in the future, Michael. So I'm going to start sharing my screen. Hold on one second. All right, can you guys see that?
Yes, we can see that.
All right. So today I'm going to be talking about novel uses of intraarticular grafts, as well as other indirect decompressive maneuvers for craniovertebral junction pathology. I think this is one really tiny aspect of spine, but it's I find it to be the most important, most interesting part of the spine. And so I've certainly worked on this problem on multiple occasions with various patients I see with craniocervical junction pathology. And I think I'm just going to go over some interesting topics having to do with this technique that's I wouldn't call new because it's been around for about a little less than 2 decades, but is a technique that certainly has become more and more popular recently. These are my disclosures. So we're going to start off with a single case example that seems to go through the most both the usual way of treating this particular problem as well as some of the newer treatment options. So this is a picture of a 49-year-old female that showed up in our hospital just a little bit before Christmas this past year, just less than a month ago, with this CT scan. And what sounds like, from history from the husband, at least 2 months of worsening gait disturbance and upper and lower extremity weakness. She shows up in the ED in extremis, having difficulty protecting her airway, significant upper and lower extremity weakness, and some level of encephalopathy. It's important to note that this patient has a significant history of pharyngeal cancer with retropharyngeal radiation, and also has cirrhosis. She got an LP in the ED that was consistent with meningitis, but we were consulted for the C12 subluxation, the basilar invagination. She was ultimately intubated in the ED, and we accepted the patient on our service, but she was extremely sick and certainly was in no shape to go to the OR for that subluxation. So after some antibiotics, we started her on some traction, and there was a reduction you could see here on the x-ray. And in a delayed fashion, we came back and did a C12 fusion with an intraarticular graft. You could sort of see that the cage sort of peeking out from underneath one of these C1 screws. With a good reduction of the subluxation and decompression of the brainstem. By post-op day 5, she was initiating her own breaths. She was treated with antibiotics, and she's still in the hospital now, requiring a feeding tube and a tracheostomy and having some other continued issues, but she's now 5 out of 5 in motor strength in the upper extremities and 4 out of 5 in the lowers. So a significant improvement. And it's usually when you can see glasses on a patient, and the post-op picture compared to being intubated and hypotensive, that's usually a good sign. So this is our post-op X-ray. So I think it's important that we sort of try to get to the meat of what we're talking about as craniovertebral junction pathology. I think that example is something that that example of the case is something we will harken back to throughout the presentation. But what we're talking about when we're talking about craniovertebral junction pathology is really just a group of 4 different types of problems. They all, in some way or another, involve some type of potential for neurological injury or ongoing neurological compression through basilar invagination or atlantoaxial subluxation or both. The different types of pathologies are the most common in adults are degenerative and inflammatory diseases of the occipital cervical joint or the C1-2 joint. And there's many different examples of how patients can fairly slowly develop myelopathy from just regular osteoarthritis at the C1-2 joint. There's atlantoaxial trauma, or instability. There's retroodontoid masses like pannuses or more commonly tumors. And then there's congenital craniovertebral junction malformations with neurological compression. There's a whole continuum of these. It's probably better described in the pediatric literature, but it goes from one end of just simple Chiari malformations to platybasia to congenital basilar invagination. And then I created this sort of 5th catch-all, and the large majority of the patients I see are sort of a combination of the top 4 and iatrogenic causes of basilar invagination. And I'll try and show examples of all of these. So treatment objectives, this is with all spine surgery, decompression of neurological elements, stabilize the pathological elements, and then restore alignment. So just some common terms, just so that we're all on the same page. Basilar invagination is the cranial displacement of the tip of the odontoid into the foramen magnum, causing brainstem compression. Platybasia, we're not going to be really getting into that particular set of issues as much with this presentation, but it's more of a congenital abnormal flattening of the angle of the skull base in relation to the C2 vertebra. Odontoid pannus certainly used to be the most common reason why I would operate on basilar invagination. It has become extremely rare now, but it's more common in inflammatory arthritis of the atlantoaxial joint, causing abnormal hypertrophy of the synovium and ligamentous complex behind the C2 vertebra. And then what I'm going to try to disabuse you of the term are reducible invagination and irreducible invagination. I feel like these are terms that we probably need to get rid of, mainly because of the indirect methods by which we can nearly reduce every type of basilar invagination. The traditional definition is the ability to be able to correct basilar invagination with cranial traction. So, the common treatment.
Hey Deb, this is Ali Baj. Sorry to interrupt.
Sure.
Can I ask a quick question on that last slide?
Sure.
And I apologize if you're going to get to it later, but I wanted, since you nicely laid out these different definitions of these pathologies, I wanted your opinion on the term or the expression cranial settling. Some folks use that kind of, interchangeably with basilar invagination. Do you think it's the same thing? Do you think it's a different process? But we do see and hear that expression not infrequently, cranial settling, as potentially a distinct entity to basilar invagination. What are your thoughts on that term?
I feel very strongly that it is not basilar invagination. I feel that cranial settling requires a pathology of the skull base, and it's usually due to a metabolic bone disease. In general, basilar invagination requires a normal skull base to be considered to be, classic basilar invagination. That being said, I have like a little slide on controversies on this. I mean, there is a continuum, and it's really difficult to actually say, basilar invagination doesn't happen in people who have cranial settling. They probably
Right.
have both, but
so for example, CVJ junction abnormality in a patient with OI, osteogenesis imperfecta. Would you call that cranial? And there's no right or wrong answer. I'm not quizzing you. Actually, I just want to know your opinion. Would you call that cranial settling, or BI, or both?
I would call it cranial settling. I think basilar invagination in the adult setting is largely either an inflammatory disease of the atlantoaxial joint or a degenerative disease of that joint. Certainly, there are these other pathologies that we talked about, and I think cranial settling is not a problem of the spine per se. It's a problem of the skull base.
Got
And
it. Thank you.
so
Thank you so much.
that's my opinion. I realize that if I said this at one of the EDS meetings, I would be booed. So common treatment algorithm here for basilar invagination. This is sort of the old school treatment algorithm. Is you have a patient with basilar invagination, they're either reducible or they're irreducible, and you figure that out by putting them through a trial of traction. And people have actually written on what is an adequate trial of traction. And then if it's reducible, then you have the choice of an OC fusion or an OC fusion with odontoidectomy, depending on whether there was enough decompression of the neural elements. The irreducible group of patients are extremely rare in this country. However, I realize there are world experts out there in this audience that see a lot of irreducible basilar invagination. Those are some really significant operations that are required for those types of deformities, and they require significant extensive decompression circumferentially as well as an OC fusion. That being said, I think my criticisms of this is that OC fusions are universally applied, but I think the real problem is trying to actually agree on what's reducible and what's not reducible. In my world, nearly everything is reducible unless all the joints of the occipital cervical junction are fused. And even then, with the proper osteotomies, it's still possible to reduce some of these. So, but that's, and I'm going to try to convince you of that. The other issues with doing OC fusions on everybody that has basilar invagination is that you're not always looking at the atlantoaxial alignment, and just an issue with traction in general. It's somewhat difficult to maintain traction with prone positioning after doing it in the supine position. That patient that I showed an example of, we put her in traction, even though I hate traction, but it was the perfect thing to do for her because it temporized her while she was getting treatment for her meningitis. as soon as we flipped her, we lost some of that reduction, and we had some changes in the neural monitoring. We had to get the fluoro machine in and approximate everything back to where it should have been before we started the case. So I think it's important. There are some real issues with this system. So why does traction work? Well, one of my mentors says it pulls the brain hole out of the spine. It really does distract, the eroded joints that are involved with basilar invagination. But it does more than that. It realigns the sublux segments. And, for people who have very small amounts of inflammatory pannus, or for tumors that are easily mobile, you can get some ligamentotaxis for decompression of the neurological elements with traction. So what is intraarticular grafting? Well, it's not really that complex of a procedure, but it was popularized by Gohl in 2004 in his paper, where he showed that treatment of basilar invagination can occur without the need for an odontoidectomy. It opens the C1-2 joint to place some sort of bone graft material or cage. And sort of the opposite of traction, it pulls the spine out of the brain hole. So what are the potential advantages of intraarticular grafting? Well, you could probably take a lot of these patients straight to the OR without a trial of traction if they have an intact atlantoaxial joint. With the right tools, you can expand it significantly, and even largely unreducible types of cases can become reducible, and you can pull the odontoid process out of the foramen magnum significant distances. It reduces atlantoaxial kyphosis. I'll show a really simple example of that. It allows for avoidance of OC fusions in a majority of cases we have presented on that subject. You could stop your construct at C1. It allows for significant fusion surface, and that's really nice to have, especially in patients where you end up doing a laminectomy at C1. You don't, and you're missing that fusion surface posteriorly. You can put something in the intraarticular space, and it's more likely to fuse actually there. And it's probably a more stable mechanical pivot to indirectly reduce odontoid incursion. And I have an example of, there's many ways to do this, but I have an example of anterior reduction of a tumor, but there are many different ways to actually pivot the odontoid out of the foramen magnum if you have a pivot point in the front. So I know this is bad luck because this is a case I did today. And I don't know how the patient's going to turn out in the long run because we're staging it, but this is how you do this. It usually requires the sacrifice of the C2 nerve root, although I'll show you a technique that doesn't require the sacrifice of the C2 nerve root. I personally do a little bit of superficial burring of the joint. Sometimes it's not really visible unless you actually do a little drill work right there. And then you place a Penfield instrument or an osteotome in the intraarticular joint between C1-2, and then with slow rotation of the instrument, you can slowly open that the joint up, and you could decorticate the end plates and then place a trial or a placeholder on the contralateral side while you put in the bone graft on the ipsilateral side. Here's a video. This was given to me by one of my mentors that taught me how to do this procedure. And this is essentially how I do it. He creates his own allograft grafts and fits them perfectly into the space. I will use cages from time to time, or I'll use allografts. There is one particular manufacturer that makes allografts that fit this shape, or you can just make them yourself. There's only really one cage that I use in this space, but the problem with the cages that are available commercially, other than the one that you might see in some of these pictures, are that they're just much too big for this space. So you could see that little piece of allograft. He just very carefully tamped it in. This is the pars of C2, and then there's the lateral mass of C1. The C2 nerve root was removed.
Deb, could I ask you a quick question?
Sure.
What kind of feedback are you getting when you insert these, the trials for these cages, as to understand that the cage size that you've chosen is going to be sufficient to reduce your basilar invagination? Are you basically getting an O-arm spin after a few trials? How are you going about it?
Sure. So for the most part, I would tell you that, and I want you to realize that this is not the only way to treat basilar invagination. I'm not one of these guys that say that this is the only way to do it. A lot of cases, and you might even see a case in one of my examples here, where I'll do both. I'll put this in, and then I'll do an odontoidectomy from the front. What I do is I do a preoperative measurement on how much odontoid incursion there is into the foramen magnum. I think that's pretty crude. After you make the measurement, that's how big of a graft you put in, and it's usually just a little bit short. But what I've found is a lot of times it also reduces whatever amount of kyphosis or subluxation that occurs at C1-2, and that in itself makes a huge difference. There are multiple technique papers on how to put in these grafts. I think for the really significant basilar invagination cases where the nearly the whole odontoid's in the foramen magnum, I don't have the guts to put in, a 10 millimeter graft. I think the biggest one I've ever put in was 8. And I think there are practitioners out there, especially I can think of a particular one in China and one in India that definitely put in much larger grafts. They use an O-arm spin after placing the graft. I use just a C-arm shot, just watching the odontoid tip come down. But they do an O-arm spin, and then they do this sort of cantilever method that allows them to actually induce lordosis at the C1-2 joint. That does a large majority of the rest of the reduction. That being said, my biggest fear with the placement of these grafts is it flying out the front. And I've definitely had that happen. And so I'm very conservative of where I place the cage. I do not put it too far forward. As you saw in that previous example, that cage was right there. And you can see here with this example, the allograft is placed right underneath the lip of that C1 lateral mass.
Now, are you doing these cases with traction in the prone position as well, or are you not doing traction?
No, I'm not doing it with traction. And the whole point of this is to pull the spine out of the occiput. So it's okay if you fixate the occiput. So this was the original paper by Goal. It's sort of interesting. He's using these homemade pieces of titanium for cages. That just speaks to the fact that there's really no manufacturers cages for this particular location, other than some of the ones that we're using off-label. You know, he is easily, you know, the innovator in this field. I mean, this is his series of 500. There's a group in China out of Beijing that essentially showed with this paper and some of their modeling that just nearly about any basilar invagination case can be done with indirect decompression. I don't necessarily ascribe to this. And then probably the most important paper recently was this group of 65 patients done by the group in Beijing, where they really showed how it is possible to do this safely with multiple different types of options for implants and techniques. So I think this is the better way to treat adult basilar invagination. You should, rather than just like, you know, divide the world into two, into reducible and irreducible basilar invagination, I think there's really sort of 5 groups of patients out there. There's the really simple ones, like the one that I showed, the AA subluxation patients, where all you need to do is just do a C1-2 fusion and reduce the subluxation. Putting in the intraarticular graft can help with some of the odontoid incursion, but a lot of the work is done by reducing the subluxation. There's the fixed AA kyphosis patients, and those are the hard ones. Those are the patients that are fused at C1-2, possibly fused across the occipital condyle, and they require the circumferential decompression, the OC fusion, the odontoidectomy, the whole deal, possibly, you know, partial removal of the clivus and whatnot. The occipital condyle pathology patients, there's very few of those patients, but I'll show you one example, and I have one coming up next week. And usually it's some sort of destructive process of the occipital condyle. There's the retroodontoid masses, the pannuses, and the tumors. Those they don't necessarily always require a C1-2 fusion, but you can definitely finish the cranial portion of the construct at C1 with intraarticular grafting and staged odontoidectomy if needed. And then there's the massive odontoid incursions, and you just use everything in your toolkit for those patients. So controversies. So you probably, I realize that Goal has made some really crazy statements about, you know, what you could use this intraarticular graft for. I don't agree with him on that. This is the panacea for Chiari malformations and, you know, syringomyelia and whatnot. I think probably we have a really good operation for Chiari malformations, and I think it works. Rather than putting in screws and rods in these patients. Instrumented fusions are probably a poor long-term decision for EDS patients and metabolic disease patients of the bone, but I realize that there are practitioners out there that do that, and some of these patients are really in desperate situations. And it's just that it's very difficult for me to offer that surgery, knowing that they're going to have complications, and also not really knowing the outcome of what's going to happen with these patients. And then I do have to say, with pediatric disorders, I feel like I have to give due deference to the pediatric neurosurgeons and spine surgeons that have been dealing with this for a while for congenital diseases. And I'm not 100% sure that this is the right treatment for congenital disease with basilar invagination in children, but it certainly does work in adults that have these types of issues. So here are just some examples, and then I'll be ready for any questions. This is a patient we did earlier this year with a congenital assimilation of the C1 ring to the occiput. They make up over 30% of all basilar invagination patients. Are these assimilation patients, and he unfortunately got a Chiari decompression and laminectomy, which resulted in further settling of his basilar invagination. He came into my clinic non-ambulatory and really in significant myelopathy. We, in this case, there's no reason to stop your construct at C1. In fact, I would tell you it'd be really hard to get a screw through there. So, you do the OC fusion. In this case, he had a really difficult C2 pars to get a screw through. So we really took it down pretty far with indirect traction and grafting. This patient, essentially walked out of the hospital.
So Deb, did you say that you used traction for that case?
No, it's not. I misused that word. I did not use traction. The patient went
okay,
to
gotcha.
the OR. We pulled on his head and then we pulled on his spine.
Gotcha. Okay. So I wanted to ask you a question about that last case. So it doesn't look like that you put a intraarticular graft in it, correct? In that case?
There is. It's
There is, okay.
So
Okay,
the problem is allografts don't show up too well on these
I
X-rays.
see. Okay. So
But
in this
there's
particular
also
case-
a graft right there in the back too.
Okay, gotcha. So in this case, it looks like that the OC1 joint is fused, obviously, right? Because
Yeah.
it's assimilated. So now you're looking at like it's almost like oblique or vertical joint between the fused.
It's really
OC1
tough to get
and
one in there.
C2.
So
So are you remodeling that joint, or are you basically just kind of putting that graft in an oblique fashion?
yeah, well, however it goes, in this case, the skull gets in the way. But what you end up doing is you have to do a little bit of burring until you get that thing in there.
And then are you doing any other maneuvers posteriorly? Are you doing like a compression maneuver, using wires to try to compress?
No, but so there is a maneuver. In this case, it just came together pretty easily. This was like this was as soon as you position the patient, this guy was gonna fall apart because this was a dynamic instability. But there is a method, it's called the cantilever method, where you underbend your rod, and then you use the occipital plate and some reduction tools to reduce the rod to the occiput. That method is what gets you that lordosis that you need at the atlantoaxial joint. I
see. And then this may be a very diminutive point, but how do you pick your LIV in a case like this? It looks like you went down to kind of mid subaxial spine. Why not stop at C3 as opposed to C6? I stop at all different levels when I do these cases, to be honest, and I don't really have much of a rhyme or reason. I'm just curious.
Yeah, to be honest with you, I can't remember. I do remember there was some stenosis a little bit lower, but from what I remember was it had the real issue here was that I had to find a level that I knew he wasn't going to get adjacent segment disease at. I knew that if I stopped at 4, that might have been probably a good level, but it would have been just like 4 screws at the bottom. I think that was my reasoning. I couldn't necessarily tell you, but I'll just be really honest. It's just the level that you think is going to hold this together, and more importantly, not develop, adjacent segment disease almost immediately, These are some infection cases. I get a lot of osteomyelitis patients. Both of these patients came in within a period of 2 weeks of each other. They both had osteomyelitis from retropharyngeal causes, but I treated them differently. One was more of a subluxation, and so that was fairly easy to do with a graft at C1-2. The other, I chose not to do indirect decompression at all. and that's what I'm trying to tell you, is that you don't necessarily have to, just do one thing or the other. In this case, the case on the right, I just thought that there's no way I'm going to be able to decompress or move this properly with that little piece of bone intervening in between C1 and 2. So this patient got the OC fusion and odontoidectomy, and it worked. Both of them worked equally well. These are some anterior distraction constructs. I don't necessarily like going transoral for anterior releases. So I do just a regular retropharyngeal. I think some of the people in the audience have seen these pictures before, but I do it just a regular anterior cervical approach to these. And both of these patients needed C2 corpectomies. The one on the right had more of an issue with a subluxation causing compression, and as soon as we were able to distract using that expandable cage, we were able to actually reduce her pretty easily. And both of these patients had cancers that had good long-term survival. Certainly you won't see me doing this type of operation for somebody that has a poor prognosis. We've definitely published on just cement augmentation for certain groups of these patients too.
Where are you resting that cage on? Is that the
anterior ring of C1? And
right.
That's how you're pulling. And so you don't have to put an intraarticular graft in the back. You could distract in the front, using a cage, an expandable cage. There are published reports of going transorally or retropharyngeally and actually sticking a bovie in the intraarticular space to release that capsule and then putting a graft in from the front. I think that is dangerous in my mind. I would have a hard time doing that procedure without hurting the carotid.
Have you done these before, endoscopic endonasal with ENT before, or are you still doing traditional transoral?
I do. So we threw out our transoral retractors a long time ago. We don't use them. We do everything endoscopic endonasal. Like that case before, that was all done endoscopically. I have the advantage of working with awesome ENT surgeons. They're some of the best in the country. And so they can get me places that, that I never thought I could get to. So like, the case here with the odontoidectomy, that was all transnasal. We've done full C2 corpectomies through the nose. And then these retropharyngeal approaches that I certainly couldn't do these on my own without ENT helping me, but they get me to the anterior ring of C1 pretty easily from the front. This is a complication, right? So this is I always present this one mainly just to show that like this isn't like a panacea. So, but this is a patient that had a giant cell tumor of the occipital condyle that was treated by a skull-based surgeon with a far lateral craniotomy and resection of this tumor. Unfortunately, you could see in that middle CT that they've sort of taken a lot of this condyle. And so the odontoid process is just sort of resting on that clivus. He came to me with some hand numbness, and this x-ray that you see here is really how he looked. He was sort of cockeyed, and could not move his head and was in terrible, terrible pain. He was a young 33-year-old. So he was offered, the usual OC fusion from I guess occiput to whatever level, I guess 3 or 4 or whatever the surgeon recommended. And he was not satisfied with that. He was a young physician that wanted to be able to continue to rotate his head. And so after getting a CTA and realizing that vertebral artery was gone and non-functional, went ahead and consented him for an intraarticular graft in that cavity where the condylectomy was done. Unfortunately, and you can tell here it was an air ball. I missed the cavity. You know, I'm way behind it. But when we were doing the distraction movement, you know, the vertebral arteries sort of popped into view where it should be, you know. But I said, oh yeah, we already know that vertebral artery is dead. You could just put this cage in right next to it. It won't be a problem. Unfortunately, it came back to life when we put the cage in, and I abandoned ship with the cage when I noticed that the bright red blood coming around. So I just stopped and just landed the cage right there, got the two ends of the artery controlled, and then the reason why you have this picture here is because this is the angio suite. Turns out that he didn't need that vertebral artery, mainly because he hadn't been using it for months. So, you know, but that was a very unfortunate complication that, you know, I just want to make sure that people realize that, you know, complications can arise. So this patient ended up growing bone across this, you know, inappropriately placed cage, and then later fused at other spots from occiput to C1.
Deb, is that because the cage was too lateral as you were inserting it? Is that how it managed to snag the vert in that particular case?
I wouldn't pretend to know, actually. I mean, you really shouldn't be putting a cage there that in front of a live vert. I think I should have taken a different approach to placement there. If I were to do this again, I've actually since done this again. I did it through a lateral approach where the vertebral artery was safely away. So, I would tell you that I was just supremely confident because I had gotten studies before the surgery that vertebral artery was non-functional. I probably should have just clipped it before I even placed the cage. So now we're going into stuff. This is stuff that I could actually claim as our contribution to this field. I think there are expanding indications for this technique, and it probably could be used for more common pathologies other than basilar invagination. And so this is a case of a patient that has just a regular type 2 odontoid fracture and was unable to get an odontoid screw due to her body habitus. As you can see, the skin crease in the back of that CT scan is really far away from the spine. So we had already developed this procedure, but we'd come up with a minimally invasive way of doing C1-2 fusions. And for this patient, it worked out to be the perfect way to do this operation, given her size. And that's, you know, the use of percutaneous screws and an intraarticular graft through small paramedian incisions. You know, and so you can see here, the first step is just to pre-drill the C2 screws, and then using percutaneous methods, placing a graft. This particular cage fits nicely in the, if you don't have to make the space any bigger, it's a 4mm graft. And then placement of the C1 screws. This is a major modification to the regular goal harms fusion in that we don't go over the C2 nerve root. We actually go under the C2 nerve root, mainly because I don't want to deal with blind bleeding, you know, in there, and I actually don't want to deal with the nerve root at all. The thing is placing those cages elevates the inferior corner of the C1 lateral mass, so that you can actually place just a drill guide in the same path and then put in your C1 lateral mass screws. And then with percutaneous screws, you can fish in a rod and fuse that. And that worked out really nicely for this lady. We've since submitted a manuscript for that, and our series, we've sort of self-selected. We only have a series of 5 right now where we have long-term follow-up. It's we now have a little bit longer than 6 months, but with this goal harms MIS modification, we're treating far more frail patients and getting a lot less blood loss. So it may be something that we may want to consider using in some of our more elderly patients where we don't traumatize them as much. So conclusions, this craniocervical distraction maneuvers are an alternative to direct anterior decompression of the craniocervical junction. There's multiple maneuvers that are available that you can use. It's just regular traction. There's traction in the prone position, in the supine position, while using intraarticular grafting. And then there's, minimally invasive transarticular grafting, which could be used for common atlantoaxial pathology. So with that, I'll take any questions.
So Deb, that was fantastic. Really appreciate you giving this presentation to us. One of the questions I have is about how you navigate around the venous plexus, that's just posterior to the C1-2 joint. So when you're doing this percutaneously and you're putting cages in there, there's obviously a fairly robust venous plexus there. How are you getting around all of that bleeding that typically takes place there?
That's if you play around with the C2 nerve root, you realize that there isn't really a lot of bleeding underneath the C2 nerve root. It's all above the C2 nerve root. So that's the whole point of doing it. Changing the trajectory of the screw is we don't put the screw through that C2 plexus, we put it underneath it. So we barely lose any blood. And I realize with MIS, in percutaneous cases, people just say, well, it's just because it's bleeding internally and you're not looking at it. We have there's really nothing going up the sucker. It's really not bleeding when you go underneath there. And one of the advantages of using that particular system of placing the percutaneous cage is that it sort of creates the way with that shim, and so you sort of create you go along the pars of C2 until you hit the joint, and then you change your hand angle of the shim, and it goes into the joint, and then you have just essentially a straight shot with the cage, and then your drill guide just goes in the same hole after you've removed the stuff that you put in the cage with.
Yeah, that's really interesting. I don't think I've heard of anyone else doing that before. Percutaneous C1-2 screws. I know when I interviewed at UNC a few months ago, you had discussed that. Ali, have you seen that before?
Yeah, I mean, doing it open is hard. Doing it percutaneously, it's really hard. So those are amazing results, and congratulations on trying to make these less invasive. I've heard of and I've seen colleagues do percutaneous lateral mass screws in the cervical spine, and even placing those cages in the facet joints. At least one vendor makes those, but certainly not at C1, C2. Really nice technique, very, very innovative. Thank you for sharing your experience, Deb.
Yeah. Deb, have you ever used, I think there's a physician in India, his last name is Chandra. He has this huge case series of these similar types of cases that you showed of doing what's called extraarticular distraction. So in cases where there's assimilation of OC1, there's this highly verticalized OC1 to 2 joint that's almost perpendicular to the floor, and it's very difficult to remodel that joint to get a cage in. Would you ever put a cage almost like more posteriorly between, the base of the occiput posteriorly and the pars of C2 to try to get some distraction? Is there ever an indication to do that?
I've done that accidentally.
Okay.
And been satisfied with the result. I think you probably need a really big graft that you have modeled properly so that you could do that. And I think that's an appropriate and very safe way of doing that procedure. So yes, it can be done, and it's probably safer for those patients to have it done that way.
Right.
And yes,
And
the people in India that do this operation are masters at it. They, like, some of the videos that you see are just amazing how they do this. There's the video I showed you was done by Tim Moore, who's actually one of the people in the audience right now. But there's also a video on neurosurgical focus from the group in Beijing that do a very similar job. They're putting in pretty large grafts, and they're obviously being very careful, to avoid the neurovascular injuries. But I think there has to be a level of comfort that you have to have with the structures around there before you start getting into the bigger graft sizes.
right. Now, are you ever doing a frame and magnum decompression as well in some of these cases?
Yeah, and I am, and I know that's cheating, right? But I mean, you got to use all the tools that you have. And so if the patient needs, opening of the frame and magnum, if the patient needs the duroplasty or something like that, sure, I'll do it.
And how about these patients that you didn't show any cases with this, but I have a few patients, pediatric patients in my practice that have a retroflexion of the dens essentially. So it's doesn't really fit the definition of platybasia, doesn't fit the definition of basilar invagination. They just have this really severely retroflexed odontoid that causes this ventral brainstem compression. How do you take care of those? Those I think would be in that rare category of being irreducible. Is that something you would do a transoral on?
Yeah, so I don't think those are irreducible. I disagree. So I think that's the exact group of patients where, like, that cantilever method actually works really well for. So there is a way to be able to open up those spaces, and then accentuate the atlantoaxial lordosis, so that that retroflex odontoid process can be pulled forward. Those patients oftentimes will need an OC fusion just to get that maneuver to work, but we're actually trying to work on that, to not use an occipital plate or occipital condyle screws. But I think they probably need it, because you're putting so much force on the hardware when you do that cantilever maneuver. So, but I disagree. I think you could do that without an odontoidectomy.
Little bit of a controversial question. How do you feel about these patients that have Ehlers-Danlos syndrome, that have these, pretty wicked high clival axial angles, and they come into your clinic with, POT syndrome and all these really bizarre GI complaints, and their neurologist claims it is coming from, this clival axial angle that is way out of normal parameters? How do you treat those patients?
I really try to avoid operating on them. Mainly because I think there's other people that are doing a better job at it than me. I think it's sort of one of these situations where I can't explain some of these symptoms from that, small change in the angle of their, skull base. And so there are people out there, and there are success stories. And I don't deny that some of these patients, do better with surgery. It's just that I have a hard time justifying an operation. These, from what I understand, these patients go to these various EDS centers. They have a trial of traction, and their symptoms all go away, and then that is the justification for their OC fusion. And I realize that probably works for some people, but the problem I have with that particular cohort of patients is that I don't understand the pathophysiology there, and I don't understand how an OC fusion is helping them. And more importantly, I fear the complications that will almost certainly occur because of their metabolic bone disease.
I agree. I've had about one or two in my practice over the last few years, and I've run it by a lot of more senior surgeons than I am, and they've all recommended basically what you said: just don't touch them. So, does anyone else have any other questions for Deb?
Well, that was great. Thanks so much, Deb. Great talking. Nice cases.
Thank you. Thanks for letting me participate.
Yeah, absolutely. I think we're just about out of time. We've got a couple minutes left. Ali, do you know what's on tap for next week?
Yeah, I think Dr. Mamagani is in charge next week, and as always, he will share with us on the different platforms what the topic is, and he usually shows outstanding cases. So Dr. Mamagani will be hosting next week.
Awesome. All right. Well, thanks, Deb. It was a pleasure. Those are awesome cases. I think you're a true expert at craniocervical junction reductions and anomalies. So thanks for sharing your wisdom with us. We really appreciate it.